the next speaker, our friend Dr. Mike Kumwenda. He will discuss the strategies to address resistant hypertension.
Good morning, ladies and gentlemen. Thank you, chairpersons, for kind introduction, and Mohammed for introducing me to Cairo. I'm still here, so many years ago. I'd like to thank the ASD for the invitation, and taking part in this Congress is always absolutely wonderful for me, and I'm hoping you're learning as much as I am. So my talk is to discuss strategies for resistant hypertension, I have split the talk so we can first of all talk about the actual definition, what is resistant hypertension, and I have split it into 3 strategies which I will go through with you, and then at the latter part of the presentation we can go through the therapeutic options of resistant hypertension. Okay. So strategy 1, we have to define what is resistant hypertension. We have to identify the patients with this problem. And in circulation, they have, thank you. They have described the uncontrolled hypertension based on the normal blood pressure reading of more than 140/90 as hypertension, and 130/80 or slightly less nowadays in diabetes with CKD, and resistant hypertension in patients with on 3 or more doses of antihypertensives, or in patients controlled on 4 antihypertensives, including a diuretic. This was proposed in 2008, and both the ESC and ESH have not changed the definition in up to 2023, and that's the same for NICE guidelines, which are the National Institute of Clinical Excellence guidelines in the UK, have not changed this definition. Okay, so if you look at this study, they took all the patients with severe hypertension that were labeled as resistant hypertension, but in fact they found out round about just over 30% had medication on adherence. Some of them had white coat effect. Some of them were undertreated, and then quite a lot of them have inaccurate blood pressure measurements. So we need to exclude pseudo-hypertension before we can label them as resistant hypertension. The prevalence has been, different in different studies, but population-based studies, it ranges between 11 and 18%. Clinical-based studies, 14 to 18%. Middle East, average 16 to 93%, according to this paper I've just put down here for you. But overall, data from prospective studies indicate that the risk of cardiovascular events in patients with resistant hypertension is double that of those whose hypertension is well controlled. So that's the main problem with resistant hypertension. So strategy 2, we have to understand the pathophysiology, the causes and risk factors. That will then help us work out the investigation, how we can investigate the patients, because we can always investigate if we don't understand the pathophysiology, causes and risk factors. And of course, part of the assessment of the patient is a proper history, family history, particularly lifestyle history of the patient, and of course we have to examine the patient. Now the pathophysiology, for hypertension, the causes are genetic, and there are some monogenic and polygenic genetic conditions that are well described, and I'll go through those in a minute. There are also environmental factors, lifestyle factors. And nowadays also on the causation, on the list is now environmental factors, which include ambulatory temperature, noise, and air pollution. All of these can actually determine how the sympathetic nervous system is working, and then it can activate the renin-angiotensin system to cause sodium and volume retention in the kidneys. And overall, all these factors then can influence the heart and cause hypertrophy, and particularly also affecting systemic arteries. And you can see the processes that can lead to total peripheral vascular resistance as outlined here on this cartoon. And then you've got the other biochemical problems that occur. So that includes inflammatory stimulation to cause nitric oxide, nitric peptides, prostacyclin, and the others to actually stimulate the whole process. And that then aggravates the situation to cause hypertension and total peripheral vascular resistance as the main driver of the complications of hypertension or resistant hypertension. The causes are genetic in secondary hypertension, autosomal dominant hypertension with bradycardia, Liddle's disease, familial hyperaldosteronism, 17-alpha-hydroxylase deficiencies. We haven't got time to go through all these. And of course, there are the renal ones that I see on a daily basis. So anything that causes CKD can induce hypertension, and particularly common are the family history of polycystic kidneys, and renal vascular disease is very common, and a lot of glomerular diseases, diabetes causing hypertension, and then all the endocrine causes. I don't have to list them for you. But the drugs in particular, don't forget that we may see patients with, particularly in the renal clinic, they have had transplants, so immunosuppressive agents like tacrolimus, cyclosporin can cause hypertension. In the general medical clinics, then the pills, steroids, all the other things that you know about can also cause hypertension. But in terms of severe hypertension, then you've got drug abusers that may also develop secondary hypertension. So strategy 3 are the actual therapeutic options, these are the ones that are important that we understand how to select these. And the actual guidelines change almost every other 2 years, but in 2018, the EAS and the ESH guidelines for management of arterial hypertension task force came up with this cartoon recommendation, and that the initial therapy, and this depends on where you are in the world, you can either use ACE inhibitors, and it doesn't matter which one you use. There's some very cheap ACE inhibitors in the low and middle income countries. You can also use calcium channel blockers or diuretic. Either single agents are okay for hypertension, but in resistant hypertension, pretty much a lot of the patients you have to combine these drugs. And in step 2, you use ACE inhibitors and angiotensin II receptor antagonists, same thing. And in resistant hypertension, then you may have to add diuretics, particularly the mineralocorticoid. Spironolactone is very cheap, so 25 to 50 milligrams a day can make a difference. And the diuretics, of course, the thiazides are very useful. And if you have patients with CKD, renal impairment, there may be the need to actually switch to loop diuretics. You can use alpha blockers and beta blockers very effectively, and they do work. Now, in terms of the calcium channel blockers, important thing is not to combine non-dihydropyridines with beta blockers, because the drugs like verapamil they also have a AV blockage action, and in combination with beta blockers can lead to severe bradycardia or even complete heart block. So it's important not to combine those, that combination. But of course, nowadays, the mineralocorticoids, we are using several different ones. In our unit, we use a pralanolone or finerenone for patients with CKD, and we now have other new drugs that have come up, and I'll talk about those in a minute. But I just wanted to talk to you again about the old drugs that we used to use, and these are drugs like clonidine, methyl-dopa, or minoxidil. So when you get resistant hypertension, if you haven't got the mineralocorticoids that are listed here, it's always important to consider these old agents. We don't use them a lot in our clinic, but now and again, patients have side effects from the group of the drugs that I've listed here, and you may wish to switch to the older drugs. And I'm sure in some clinics in Egypt or in the low, medium income countries are still using the older drugs, because obviously cost is an issue. So if you're getting stuck then with the patient is still not reaching target blood pressures, then what do you do? And this came up some years ago. You may be familiar with a Simplicity HN3 trial. This was done in 2011 to 2013 in 88 centers in the US. They randomized 1,448. Mean age was 57.7. So one group had renal denervation, and the other group had a sham denervation, without denervation. There was no difference in blood pressure control at 6 months. Patients who then had sham were allowed to cross over to the renal denervation procedure if they wish to. And more recently, there's been a follow-up study to look at those patients that were randomized to renal denervation at the beginning, and the ones that went into crossover who had been on sham procedure, and they looked at the data at 36 months. And that data has shown an office blood pressure reduction of 26.7 versus sham group of 7.4 systolic blood pressure reduction, and 24-hour blood pressure reduction of 15.6 versus 0.3. This was statistically significant to the point that now part of the recommendation for resistant hypertension management is renal denervation. You can see here that actually in the recommendation for blood pressure, the consensus statement from the ES Council on Hypertension and European Association have come up with the suggestion that renal denervation, if you do have the facility, should be considered. You can see here in this cartoon here that there are two catheters that they can be used. There is a spiral catheter on the right, on the left, and the Paradise catheter on the right-hand side. Now, in the Simplicity study, it was obvious that the technique that they use with the catheter, the frequency that they use, may have affected the results. And you can see the studies, earlier studies of the procedure didn't show any difference in the patients who had sham versus the patients who had renal denervation. Whereas the newer technique using the spiral catheter are showing a difference in treatment. So the patients that have had renal denervation, the blood pressure control is better. Now, the full story is that this has been going on for such a long decade, and the studies in green have shown some benefit, but not terribly convincing, and the other ones have showed actually harm to the patients, and the other ones were negative studies. So this is a study that's looked at what has been the situation in patients who had the treatment over 2008 to 2014. And they took patients, 163 patients, and looked at what happened from baseline to a 9-year follow-up period to see what's happened to the blood pressure control. So in 61 patients, you can see that the systolic blood pressure running just over 130, 140 to 160 had come down significantly in the long-term follow-up period. And the same thing has happened with the diastolic blood pressure on the right-hand side, showing actually it looks like this procedure actually makes a difference to resistant hypertension. I have to confess that I have got no personal experience in my clinic with this procedure, but I know a center where I can send my patients if I need to send them to somebody else who can help us with patients that are not reaching target lowering of blood pressures. So in the last few minutes, just wanted to discuss with you that there are also other antihypertensives that have been licensed for the use of patients with severe hypertension or resistant hypertension. And this is the trial for the baxdrostat that was published in the New England Journal. And this is a multi-center, double-blind study, placebo-controlled trial that assessed the safety of baxdrostat in adults with resistant hypertension. They took 275 patients who were receiving 4 antihypertensives to include a diuretic, and they gave baxdrostat at the doses of 1 milligram, 2 milligram over a period of 12 weeks. And you can see there was a significant reduction of systolic blood pressure in the patients. That was the response was dose dependent. And the conclusion of this study was that in adults with treated resistant hypertension, aldosterone synthase inhibition with baxdrostat at the dose of 1 milligram, 2 milligrams led to significantly greater reduction in the systolic blood pressure over 12 weeks period. So this is now available, and there are several other aldosterone synthase inhibitors that have also come on the market, and I'm sure we'll see more trials come out in the next few months. So this is an algorithm which I think would be useful. So you've got your confirmed resistant hypertensive patient. You intensify the intervention with your whatever available drugs in your clinics that you have, to include angiotensin receptor antagonists or ACE inhibitors. If you're still struggling, then obviously you need to send them to somebody who has special interest in hypertension management. And in those patients with eGFR above 30 mils per minute, then you can add spironolactone or any other mineralocorticoid that you have available in your unit. You can use a beta receptor antagonist or alpha receptor antagonist, or the old drugs I mentioned, the centrally acting agents. And if the patient is still not reaching target, then consider them for renal denervation. On the other hand, in those patients who have an eGFR of less than 30, so these are the ones that are ending up in my clinic, then you can use chlorthalidone in preference, or any other diuretic that you have, beta receptor antagonist, alpha receptor antagonist or central acting agent. And if that doesn't work, then of course, we now got the the newer drugs that we have already talked about, and that will depend on whether you have those in your unit or not. So the aldosterone synthetase inhibitors have come out, and I'm not quite sure which ones are available in Egypt. So in conclusion, I would say true hypertension, it does exist, but you've got to make sure that you have excluded pseudo-hypertension. You've got to make sure you've excluded white coat hypertension and those patients that are non-compliant or those patients that are not tolerating drugs. And then we know that it's very important to treat these patients because if untreated, then uncontrolled resistant hypertension has a twofold increase in cardiovascular events risk. Therapeutic options, of course, we can't ignore the old ones, and of course, it always depends on which ones are available in our clinics and how much they cost. But at the end of it all, we now got novel pharmacological compounds that we can use in this group of patients. I have to say, the hypertensive patients I have seen in my clinic, I haven't had to send them for denervation, but there's only one patient that we are thinking about sending them to Scotland to one of our colleagues that does this procedure. And the catheter-based renal denervation, still not in a lot of experience published yet, but it looks very positive that we should be considering for resistant hypertension. Mr. Chairman, thank you very much for your
Thank you very much, Mick. Very clear presentation on resistant hypertension.